We're going to have Susan Lyon and Louise McGee, who are going to talk about coordinated clinical care. We'll have an opportunity for Q&A just after that. We're going to have Alison Blackett and Claire Letham, who are going to speak about steps and some questions after that. Then Kirsty Ann McEwen is going to speak about mentalisation based therapy. Tim Sporrell is going to look at dialectical behavioural therapy, and Kirsty Gillings will look at schema therapy. And then we'll have a question and answer session based on those three previous speakers. All the way through, would encourage people to put some of their questions in the chat box. Just to the side, I'll just go over some of the general housekeeping just now. So for people that are not familiar with the MS Teams, you'll notice there's a control bar up the top. There's an icon for chat, there's an icon for reactions. We've got everybody apart from speakers on off camera and muted just now, just to try and preserve some of our bandwidth a wee bit. So we'll be expecting, say, upwards of 200 people maybe attending today, so it can cause Teams to creak a wee bit. So if anyone has any questions, pop them in the chat box, and we'll have opportunities. Behind the scenes, we will look at the questions, and we'll have that Q&A slot after some of the speakers. If we're not able to answer all of the questions today, and to be fair, I don't think we've ever been able to answer all of the questions on the day, but we will produce a kind of comprehensive question and answer sheet that will be sent out to all participants today. So all of the questions will be answered after the fact, even if we don't have time to do them all today. Can I have the next slide, please? Okay, so we will be recording the link, and it'll be posted on YouTube. So if you want to watch anything again, it'll be on there. Or if you get any colleagues who've not been able to attend today that you feel might benefit from some of the stuff we're talking about, they'd be able to access it there as well. Next slide, please. So the agenda that I've just went over there, and I think approaching 4 minutes past 11, I think we're probably good to go. We've got 185 people. We've got 209 people on the call. A busload just arrived. So will we get cracking straight away, and I'll hand you over to Sue Lyon and Louise McGee.
Thank you for that, and good morning. My name's Susan Lyon, and I'm recovering from a cough, so I'm going to try and not splutter my way through this. And along with my colleague Louise McGee, I'm going to talk to you this morning about a coordinated clinical care training programme for staff in NHS, Greater Glasgow and Clyde. If you could go on to the next slide, I'll talk a little bit about the background of how coordinated clinical care came to be. So many of you may remember the 2003 paper, Personality Disorder, No Longer a Diagnosis of Exclusion, written by the Royal College of Psychiatrists, which identified and considered it necessary to specify as one of its aims that personality disorder should be considered legitimate business of mental health services. However, in a strategy day in 2016, it was highlighted that despite improved understanding of the disorder and progress in identifying effective treatments, it was not clear if that aim had been achieved. And so ongoing reviews and reports produced both by the Royal College of Psychiatrists and the Mental Welfare Commission, it was acknowledged that there was disparity in how services were approaching personality disorder, and it was identified that personality disorder should remain high on the strategical health agenda. So the Greater Glasgow and Clyde Mental Health Strategy, the 5-year mental health plan moving forward together, reported on the differences in knowledge, skills, attitudes and practices between individual clinicians and services. And it also noted that there was no best practice framework to direct and support clinicians in their roles. And so the need to address this was highlighted as a strategic priority. The Borderline Personality Disorder Implementation Steering Group was set up, which answers to the Strategy Bed Workstream Group, and that identified a number of recommendations, which included a staff training programme, and so coordinated clinical care was developed. Next slide, please. So the training is a one-day multidisciplinary programme. It's designed for all clinical staff of all grades, and it's designed around how to work well with borderline personality disorder. The training content was developed by Dr. Andrea Williams, who is the clinical lead for the Personality Disorder and Homelessness Service in Glasgow, and Dr. Michelle Veldman, who is the principal clinical psychologist of the DBT service in Glasgow. It was initially designed for an in-person delivery, and it was piloted in that format during 2019, so intended to be delivered to whole teams. However, COVID came along and demanded the need to adapt it to be compatible with digital delivery. Rollout of the format in this form commenced in February 2021, which was 11 months behind schedule. Next slide, please. So the Coordinated Clinical Care Framework underpins the BPD care pathway in GG&C, and it supports the process of assessment, diagnosis and formulation of problems. It's part of the crisis planning and supports transitions to maybe longer term structured psychological therapies, which may include the emotional coping skills groups and the STEPS group, and also the longer term psychological therapies that are both one-to-one and group, and that's Dialectical Behaviour Therapy and Mentalisation Based Therapy programmes. Next slide, please. The objectives, it's designed to introduce a best practice framework, so a clinical framework which could be considered the kind of mainstay of psychiatric care, best practice psychiatric care. It emphasises throughout the whole day the idea of empathy as being a clinical intervention, and the intention is to embed empathic and validating culture in clinical practice. It hopes to improve understanding and skills across clinical disciplines, so all clinical staff who have contact with patients. And it's designed to address the stigma and controversy that surrounds the diagnosis. It's designed to work alongside people with lived experience and gain their expert insight about what works, what their needs are, and how services can respond more effectively and more helpfully. And it's designed to improve the service user experience of contact with services. Next slide. So the resource we have for this training programme is 2 one-day-a-week trainers, so both from clinical background, myself and Louise. We work in collaboration with the BPD Dialogue Group, which is a section of the Mental Health Network forum. So that's people with lived experience who have come along, who have been part of the development of the digital delivery, have helped us assess and reflect on what's helpful, what are the important bits, what's the message that they want to get across. The aim is to deliver 3 training days a month, with the other day as a sort of admin, updates, evaluation, sort of looking at the feedback that we get from each training day. The digital platform that we use is the Microsoft Teams. So this forum, we aim to have a maximum of 30 participants per session. I think on average we've had around sort of 15, 20, perhaps a wee bit less at the kind of height of there is staff and resource crisis at the beginning of this year, but we're kind of edging up to sort of mid-20s. We've never filled a session to capacity, and I think that really is just a reflection of the climate and how pressured staff are. We get admin support from the existing psychological therapist training team, so that's a wider training network of administration. And the whole training programme is supported by the training subgroup of the Personality Disorder Implementation Steering Group. So we meet up about once every couple of months with that forum to just make sure that we're that it's all joined up, that we're on track with what our intentions are and with how the training is being received and developed. Next slide, please. And I think I'm going to pass you over to Louise at this point.
Yeah, thank you, Susan. So the training is delivered over a day, and it is a really, really full day. I guess one of the things that we always hear from participants is that they would like it to be spread over a longer period of time, because we do pack in so much information into the day. So we really think about different theories of personality development. So we talk a lot about attachment. And really, we think this is important to help develop empathy, not just for clinicians towards the service users, but also for our clinicians then to help translate that to our service users as well, to build empathy and compassion for themselves. We have really been looking at the diagnostic changes because really this is potentially transformational when looking at this diagnosis, taking it from categorical to a dimensional sort of view really can instill lots of hope and helps sort of us be more recovery focused, and this idea that this is a treatable disorder as well, which again can be quite a different way of thinking for some clinicians and for some service users as well. We do talk a lot about acknowledging challenges, and I think that this is where this training is really quite special, because we really invite our clinicians to be able to speak freely, to voice the views that they hold, the challenges that they find. It's a really open and safe forum for our clinicians to be able to do that. We try to promote principles of good practice, skills and strategies. So not just teaching new skills and strategies, but also highlighting what our clinicians are already doing well. We talk about treatability, and we provide evidence about treatability as well, which can be, again, quite eye-opening for some of our clinicians too. And we talk about the evidence-based therapies. We also do try to provide some skills that our clinicians can use that are rooted in evidence-based therapies, but you don't necessarily need to be trained in the full therapy to be able to use. So again, emphasising that this is a core approach. And we also spend a lot of time talking about the importance of team and individual support. So we are supposed to work together as teams. We hold things as teams, and the importance of supervision and thoughtful allocation for patients as well. Next slide, please. So throughout, we've been trying to get pre and post outcome measures to get a sense of how well the principles are being embedded. But this has been extremely challenging because the differences that we're trying to measure are really difficult to quantify. So really what we've been looking for are changes in skills, understanding, clinician confidence, empathy, and attitudes. So we do a 3-month follow-up, we do evaluation questionnaires, and we also have identified link workers within each of the CMHTs that we meet with regularly to feedback. So they'll let us know how they feel that the training is being embedded within teams. And we talk about ways that we can address any challenges that might arise as a result of that. Next slide, please. So during our last pause, we managed to have a look at some of our numbers. So from February 2021 to September 22, we managed to deliver 44 training sessions, and that was around about 460 staff members that were trained. And as you will all be aware, when you send out questionnaires, you tend to get a very small percentage of them back. So really, we cannot draw any broad conclusions as of yet. However, we have seen improvement in our key target areas. The conversations that we've had with our link workers certainly suggest that staff members who've been on the CCC training feel more knowledgeable, and they feel better equipped to support their clients. And service users have reported an improved experience in terms of working with their key workers and within CMHTs as well. Can I have the next slide, please? Thank you. So again, these numbers are really not a whole lot can be gleaned from them. Really good number of outcome measures, very, very few in follow-up. And I think that this is really reflective of you know, the demands that our staff are currently under. We're sort of working again still in quite an unprecedented environment. And so in general, if I'm being very, very generous, we can draw some favourable conclusions, but really this is, I think, something that we have identified that we want to work on going forward, a better way to measure and evaluate the outcomes. Can I see the next slide, please? Thank you. So I think that probably going forward, we're going to be looking at more qualitative measures to be able to really investigate and evaluate how well change is being embedded and how effective this training is. These are some of the key words that have been allocated from some of the feedback that we've had. So lots and lots of positives. I think people feel that they are more informed, that they have a better understanding, that they feel a bit more confident, that they've had an opportunity to sort of share their views. But certainly we've also had people ask us if we can move to face-to-face, and you know, there's a lot of screen time, lots of screen fatigue. It's a long day. So this is all information that we use and try to embed when we pause. We try to adapt the training to incorporate these suggestions. Next slide, please. So what we've found so far is that the training has been compatible with both in-person and digital delivery. So far, I've only had a chance to deliver it online, but it is still really effective, and you do get lots of opportunity for discussion, which is what really makes the training. It makes it rich, it makes it relevant. So far, we do see some evidence that it has been effective in achieving the key target improvements that we're looking for. We do need more work, I think, to maintain the improvement over time. And we've sort of spoke about some strategies we might be able to do to work on that in the future. Really lots of opportunity to develop the link worker roles. And, you know, the feedback we've had is that it is really, really valuable training. Next slide, please. So really, what we would be hoping to do to really make the most of this is to increase our trainer resource to be able to deliver it more widely. We have been working on developing further lived experience contribution, which is really exciting. We've actually had service users develop videos for us to use in the training, which is just has been a remarkable part of the day to see our trainees' reactions to these videos. It's really wonderful. We are looking to extend to additional service areas. I think CAMs are already going to be adapting a format of this training to use, which has really which has been fantastic. And we're hoping to be able to embed it in things like junior doctor training programs, adapt it for non-clinical staff, and maybe looking at top-up sessions to embed the principles and practice as well. Next slide, please. Right. So that's us. That's us finished. Any questions?
Funny you should ask that. There absolutely, there are a few questions now. I'm going to read them off the other screen. So someone has asked, is the training just for GGC staff, or can other boards access it too? Andy has already helpfully kind of answered that a bit in the chat, but just in case people haven't seen the answer, I'll read Andy's answer. She says, at the moment, it's GGC only and has elements in it that are specific to the therapies available in GGC. I'm sure this could be adapted for other health board areas, and Andy has encouraged people to get in touch with either you guys or with her directly as the clinical lead in GGC, and Andy's GGC email address is there in the chat for people who want to take that up. I think from my perspective as the delivery lead for the PDIP programme, I think this is something that we have observed has been a really useful approach, and something that's maybe not available in a number of other health board areas, and it's likely that this might form one of the areas that we would be making some recommendations get into phase 2 of our work post March, about a more national approach to some of these training needs. Okay, so next question was, would the training be available to non-medical staff? Many of the people that I support have a diagnosis of BPD and they often don't have a CPN.
We would love to do that. So we know that service users with this particular diagnosis come into contact with lots of different services. And really, I guess, when we talk about coordinated clinical care, we don't just mean within, community groups and with our wards. I mean, we mean with any service that's coming into contact with this patient group. So ideally, we would absolutely love to do that, but we have such a limited resource that we're still really currently focusing on the rollout to CMHTs at the minute.
Yeah, but as you say, so you're looking to actively increase the number of trainers that you've got, so potentially there's scope for that going forward. Great.
I should also maybe just note that it is available to social work staff who are integrated into our health and care partnerships. And also I see there's a note there about non-qualified staff. So yeah, we've had students along to the training as well.
Okay, that was my question. It was a good question, wasn't it?
It was a great question.
Thanks. So another really good question is, are people with lived experience involved in the delivery of any of the sessions? I know you'd spoke about working with the lived experience group within GGC, but is it? So that was the question, I suppose. Are any people with lived experience involved in delivery?
So not currently, but again, that is something that we have also discussed and would be really keen to try and develop as well. So far, what we have are videos that we have gone back. We've spoken to the service users that we're working with. We've sort of they've seen the training as well, so they've actually sat in and sort of watched some of our training sessions and things as well, and we've sort of done wee sessions for them too, and so we've spoken about certain areas of training that we thought would be really helpful to actually have their input in as well, and they've made us videos that kind of tie in with these sections as well, but we're always looking to build on that input.
Okay, so there's a question here that says, in the training days, are all doctors, including consultants, receiving and accepting the training? So,
short answer is no. The slightly longer answer is, we have representation from all disciplines. And I guess what we acknowledge at the training is that the people that are coming along to the training are the people who are bought in, who are absolutely kind of, invested in developing their skills and getting it right and joining up and being coordinated. And, there are pockets of staff across the health service area that haven't come along yet. Now, whether that's about accessibility, whether it's about pressures of work, but certainly we are getting all disciplines of all grades, but not everybody has been along yet.
There's another question asking if the training is available to older people's community mental health team staff in GGC.
Again, short answer is no, not yet. They're not part of the priority staff group, but we have had representation from older adult, particularly CMHTs, community staff. And I think that's partly about, that people are becoming aware that the training is available and people are getting access to booking links and booking on. So we've had representation from staff out with the priority group, and I guess so long as it's not subscribed to the maximum, you know, we're not at capacity, then we're okay with that, and we just acknowledge on the day that some of the content, like for example accessibility to the psychological therapies, isn't available to older adult services as yet. So it's just about acknowledging some parts of it won't be quite as relevant. But I think that the whole sort of theme of the training and the whole concept and principle embedded in it is relevant to all staff.
That's great, thank you. And I think this is my final question. Someone asks, noted that the post-evaluation questionnaire suggested no change in negative beliefs towards a diagnosis of BPD from pre and post evaluations. Why do you think this is the case, despite the level and intensity of the training? I note that you had sort of prefaced the analysis side of it down. You'd mentioned the kind of low numbers in response to that questionnaire, which may be a factor or not, but it'd be good to hear a wee bit more about that.
Yeah, I seen that question in the chat and I went, oh, because when we were doing the analysis, when I saw these numbers, I had a panic attack as well. I think I went to Susan and Andy and Michelle and I was like, what's this? Do you know, I think that there's a number of reasons for it. I think, you know, as we've acknowledged, the follow-up has been really quite low, and actually even compared to the amount of people that we've trained, and we've had over 400 people attend the training. Even our pre-outcome measure, we only had 174 back, and in our 3-month it was 39. So I don't know if it's maybe in the way that we have phrased and worded the questions. We would need to really go back and have a look at that. Another thing could be that actually we are working under huge amounts of pressure just now. So maybe there's something about that as well, the climate that we're working in with our patient groups too. But the honest answer is I'm not sure, because when we look at the rest of the numbers, they don't really seem to support that, finding as well. You know, if we look at the increase in empathy and compassion, if we think about the increase in skills for working, if we look in the increase in understanding of BPD and confidence to treat, but the only one that seems to be slightly sort of elevated is the negative beliefs about BPD. So I'm really not entirely sure what that's all about, but I don't think it really is an accurate reflection of the experience of people who come to the training.
That's great, thanks, Rich. There are a number of other questions coming in, but we need to try and keep to schedule. What we will do is we'll put all of these questions to the speakers, and as I said at the beginning, that there'll be a full list of the questions and answers are distributed to everyone on the call. Thanks very much.
Thank you.
Thanks, guys. Okay, so next up we're going to have Alison Blackett and Claire Latham speaking about steps. Thanks.
Oh, hi there. So yeah, my name's Claire Latham. I'm a cognitive behavioural therapist and I work in the psychological therapy group service. I'm going to talk to you a wee bit about who we are as a service and what STEPS is. And I'm going to pass you on to my colleague Alison, who will talk a bit about developing capacity to deliver STEPS and what we've learned in Greater Glasgow and Clyde. So could you go to the next slide, please? Okay, so the psychological therapy group service, we're a fairly recent development in mental health services in Greater Glasgow and Clyde. We started in October 2020 and we provide psychological therapy groups to people attending 18 community mental health teams across NHS Greater Glasgow and Clyde. So I'll put the contact information for our service in the bottom of the slide. We're based at Levendale Hospital. Can we go to the next slide, please? So just about a wee bit about what we deliver to our patients. The psychological therapies group service currently delivers emotional coping skills groups for emotional dysregulation. behavioural activation in groups for depression, the unified protocol for anxiety disorders, survive and thrive in female-only, male-only and mixed cohorts, acceptance and commitment therapy, or ACT, for long-term physical conditions, the STEPS programme, and stairways. So I'll talk a wee bit about what STEPS is and how we're delivering it at the moment. But our intention is to deliver 8 cohorts per year in partnership with the community mental health teams, accepting 96 referrals a year. Next slide, please. So just a bit about what STEPS is. So STEPS is a programme that was developed by Nancy Bloom, who's a senior social worker and faculty member at Iowa University. She's now retired, but she developed the programme with her colleagues 20 years ago, and it's used in many places around the world. So it's a group treatment programme for borderline personality disorder, and the acronym is Systems Training for Emotional Predictability and Problem Solving. Next slide, please. So STEPS is an evidence-based psychological therapy for patients with symptoms of or a diagnosis of borderline personality disorder. It was initially developed to be a face-to-face group, and we ran it in NHS Scotland and various health boards as a face-to-face intervention for many years, usually taking place in community mental health teams. So traditionally it's a 20-week programme. It consists of a 2-hour face-to-face group plus a 30-minute individual or small group reinforcer session to reinforce the materials of the group session. All of the face-to-face groups were suspended because of COVID, and that was around about March 2020. So in the summer of 2020, we had some groups that were suspended. Some of the face-to-face groups, had people on waiting lists waiting to start STEPS programmes all across Scotland. So there was a group of staff got together to look at the programme and figure out ways of developing it, updating some of the materials to be able to deliver the programme digitally. So some of the groups that had started face-to-face had been suspended and eventually resumed digitally, and then we were able to start some new cohorts fully digitally. Next slide, please. So STEPS is a skills-based programme, so we teach a number of different skills in distancing, communicating, challenging, distracting, managing problems, setting goals, eating, sleeping, exercise, leisure, physical health, and abuse avoidance. And then we move on to relationship behaviours. Next slide, please. So the next 3 slides really go into some of the evidence of STEPS and why we use it across the world, really. There've been several uncontrolled studies and randomised control studies. So I'm not going to go into any of the details, but the references are in the next 3 slides, just so that you've got them when you receive your pack if you want to look into this evidence. So can we just move through the next 3 slides just so that people can have a wee look at that. So can we go back? Sorry. Oh. If we go to, yeah, so next slide. And then the next slide. Okay. So before I pass over to Alison, I'm just going to talk a wee bit about our experience of delivering STEPS digitally through the psychological therapy group service, along with our colleagues in the community mental health teams and our model of implementation. So pre-COVID, face-to-face groups were run in the community mental health teams. In the summer of 2020, the Scotland-wide group looked at the materials to modernise them. So we got in touch with Nancy Bloom and got permission to update some of the materials, make some new PowerPoint slides, and we got together as staff to make some videos so that we could maybe play some videos to our patients attending the groups, or to have the video played ahead of the group so that the steps could be delivered in form of discussion groups. So we've got different options for delivery. So the Scotland-wide group still keep in contact. We still update each other with the information about training resources, new materials, try and keep ourselves up to date. So we've developed a Microsoft Teams channel for that purpose, and that keeps us abreast to very recent developments. So from spring 2021, the STEPS groups were able to resume, and new cohorts started digitally. So through our service with the CMHTs in Greater Glasgow and Clyde, we were able to run 7 groups in 2021 and 6 groups in 2022. And most of these groups have approximately 10 patients in each group. So I'm now going to pass you to Alison, who's going to talk a wee bit more about the developing capacity and what we've learned.
Thanks, Claire. So I'm Alison Blackett. I'm a consultant clinical psychologist in GGNC and one of the professional leads for adult mental health and that health board. So can we move on to the next slide, please? So I'm going to focus a little bit more on the task that the groups service had in terms of building sufficient capacity within the staff team to be able to deliver steps at the scale that we were intending to deliver. As Claire mentioned earlier, our intention is to deliver with our CMHT partners 8 steps cohorts a year, with capacity to accept 96 referrals in total into those groups across the year annually. So as Claire mentioned, the group service was relatively new in GGNC. It's around 2 years, almost to the day, since we went operational. And we started in December 2020 with only 1 member of staff trained in steps. And almost the timing couldn't be worse, because that was at a time when taught steps training that's usually available through NES in Scotland was not available at that time. So we had to think quite quickly about how we were going to build capacity to be able to deliver steps within the group service. Could we go to the next slide, please? So what we did was we made links with who we knew were sort of champions of steps, if you like, in each of the 4 adult mental health localities across NHS, Greater Glasgow and Clyde. We also made contact and liaised quite closely at that point with the steps expertise in Scotland around how we could feasibly build capacity in our staff team in the absence of being able to access taught courses and steps training courses that we would typically have accessed. As Claire mentioned, we contributed to the national work, which was ongoing at the time, to digitalise the STEPS materials and the STEPS programme. And again, that gave us relationships with STEPS champions, people that were passionate and committed to STEPS in Scotland. And we negotiated how to work in partnership with our colleagues in CMHTs and GGNC that were STEPS trained. So we moved forward with a peer-to-peer training approach in order to upskill our staff in STEPS in order to build this capacity that we needed to meet our goals. So if we move on to the next slide, please, I'll say a little bit more about that peer-to-peer training approach that we used. So the group service, we attached a member of our staff to each cohort that was being delivered in GGNC, and that was being delivered by 2 STEPS steps trained and experienced facilitators from across GG&C. We attached a member of staff to that as a third facilitator, if you like, for that entire now 21-week programme. The steps is now 21 weeks because of the digital version that we now use. But I suppose the quid pro quo for that was that we provided the expertise that we had already developed by this stage in the digital delivery of psychological therapy groups generally across the other groups that are on our roster. And we provided the admin support and the infrastructure to be able to invite people to the meetings, to administer and get back their pre and post outcome measures, etc. So we provided the admin support for these groups. And working in partnership with our CMHT colleagues in this way, we managed to go from just one STEPS trained member of staff when we started the service 2 years ago to now having 9 people in the service trained in STEPS and able to deliver STEPS and contribute to that delivery. So the next slide, please. So over that time, over these past 2 years of embarking on this capacity building plan around STEPS and being able to upscale our delivery of STEPS groups, we've taken various forms of feedback as a service. We take feedback at various points and junctures. So we obviously take feedback through the screening process with our participants who are considering coming into a group. We use clinical outcome measures at pre and post and also at midpoint in STEPS. And there's a session by session type of clinical outcome measurement that happens through STEPS also. We take feedback during and after individual group sessions. There is a STEPS specific feedback form that we ask participants to complete when they've come to the end of a STEPS programme. And we also use a general feedback form that we apply to all participants coming to the end of any of the groups on our roster. So we've got various sources of information that we're able to, I suppose, interrogate and try to work out what's worked for us over the last 2 years. So the next slide, please. So the next couple of slides are, again, just some verbatim comments that have been gathered from participants that have engaged in STEPS. So I won't go into them in any detail. It's a very small on this slide also, but it is in the slides for you to peruse at your leisure if you wish to. But we just wanted to give a flavour of the type of comments that people tend to give about participation in STEPS, particularly more recently when it's been a digital version that's been delivered. So this is multiple quotes from Scotland-wide patient feedback that's been gathered from across Scotland. And the next slide, if you don't mind moving on, has some more verbatim comments from our own group service feedback about STEPS and about the experience of STEPS. So we have used that, as I'll say as we move on, just to help inform our next steps and what we're planning next with the graduate programme for STEPS. I'm going to say a little bit about that just as we move on. Next slide, please. So I'm just going to say a little bit. We have obviously amassed a lot of data in the 2 years that we've been delivering multiple STEPS cohorts with our partners and CMHTs. So I'm just going to say a little bit about our process now of beginning to interrogate that data that we've amassed. So 2 of the outcome measures that we use around STEPS are the Core 34, which is an overall measure of psychological distress, and the Work and Social Adjustment Scale. So we have looked at a census period. We took a bit of a snapshot in time, and there were 6 STEPS cohorts that were completed during that window of time that we were interrogating in this particular look at our data, if you like. So we had, as our previous speakers spoke about, often the return rate on questionnaires isn't as we would hope, but we had 18 people that completed both the pre and the post suite of outcome measures that we asked them to. So that's a return rate of around 75% of people that completed steps with us, not of those that started. That's clearly a higher number. So can we go to the next slide, please? So all that's on this slide is showing you that we have observed improvements in participants' core outcome measure, and that is at statistical significance. So we're seeing statistically significant change and improvement on participants' core measure. The work and social adjustment scale, we've seen improvements, but not at statistical significance. The next slide, please. So some of the obstacles that we've encountered over the 2 years that we've been delivering steps in this way in Greater Glasgow and Clyde. Access to technology, that's a very familiar story for both participants and for staff at times, to be able to deliver groups digitally in the way that we're delivering at the moment. So just having a device with a camera and a mic, having access to a stable Wi-Fi signal, all of these things can prove to be obstacles for both participants and staff, as is access to private space. So for staff, that has been a challenge because we have some accommodation pressures across our health board at the present time, and also for participants to be able to have that private space to join a group from their home environment, if that's often where they're joining from. We still have clearly a group of participants who have a preference or a need for face-to-face delivery of groups rather than the digital delivery that's the current offer. And another obstacle that we've encountered, as again our previous speakers mentioned, access to people, staff members that can act in this reinforcer role, that can have this 30-minute contact with participants working through steps each week to reinforce and encourage and embed the skills practice. That has been challenging at times because of the staffing pressures that we're facing in our services at the moment. On to the next slide, please. And again, this slide is just giving you a flavour of some of the comments that we've had back from participants engaging in steps about the obstacles that they've encountered, with some of the materials and with some of the digital method of delivery that's being covered at the moment. So I won't go into that huge amounts of detail, but it's there if you want to sort of ponder on that, if that's relevant to your own thoughts about your own service delivery, etc. at the moment. So move on to the next slide. What we've learned then, I suppose in summary, over the past 2 years of delivering steps digitally, we've learned that we can do that, that it is possible and feasible to deliver steps digitally, and actually that method of delivery is a preferred method for many participants that come through our service, but not all. We do have a population of people that would prefer face-to-face groups. I suppose we learned really quite quickly and dramatically that when we work in partnership with our CMHT colleagues and pool our resources, that we were able to really quite quickly build capacity in the workforce to deliver steps. We learned that peer-to-peer training approach that we had to adopt in the absence of taught steps training was very high quality. It's a gold standard in some ways, being able to see a live steps group from its beginning right through to its end being delivered by trained and experienced facilitators. And we intend to retain an element of that peer-to-peer training model, even when our access to NEST courses has now resumed, which we're absolutely delighted about. And I did mention that we are currently in the process of implementing Stairways, which is a follow-on group from STEPS. It's designed for a sort of graduate group, so people that have completed steps can go on and have access to a Stairways group, which is over a longer period of time. And we really pushed on with the implementation of Stairways as a direct response to the feedback that we were getting from participants about steps. What now, what next, how to sort of really consolidate the learning and steps over a longer period of time. So we are excited about beginning to implement stairways and what that will bring to our roster of groups that we can offer participants in GG&C. And I think that's my last slide. So I'll stop talking there. Thank you.
That was great. Thanks very much to both of you. So we've got a number of questions. We're a wee bit over, so I'll just fire straight into them. You've already answered some of them. So there was a question around about that plan to continue the peer-to-peer city rollout, and the answer's yes. So first question is, what are your thoughts on steps as on an individual basis for other personality disorder diagnoses?
Sorry, do you mean delivered as an individual therapy on a one-to-one basis?
Yeah, that's how I read it.
That's what the question is. So I personally have got no experience of that whatsoever. It's only group delivery that I've had experience of. Claire, have you had any?
I suppose steps in itself designed as a group intervention, so there's that level of peer support. Because you get the individual as part of the reinforcer session usually. I would suggest possibly not. There might not be any evidence for delivering on a one-to-one basis, and for other diagnoses, I suppose we would need to look and see, was there evidence for a programme? There might be something that could be developed or tweaked, but maybe steps in its current format is more to do with group delivery.
Yeah.
So there were another couple of kind of link type questions. So one of them was, what can be done to help patients who've got massive social anxiety and they're fearful of attending groups? The patients that kind of fall in that group, do they have a period of one-to-one support or help with CMHTs first to get them to across the start line for steps?
That's exactly right, Gordon. So because we work in a partnership approach with our community mental health colleagues, we are working in partnership with them in terms of people's readiness for a group-based intervention and getting familiar with using maybe Attend Anywhere or MS Teams for appointments, just to try and sort of socialise people to that way of working. So yes, that would be very much the approach that we would take. Also normalising that, Gordon. I think most of the people that come through groups through our service have quite an element of anxiety. It's quite a daunting prospect to come to a group. So normalising that, and we'll talk, with all participants through the screening phase. People have a one-to-one appointment with us to screen for suitability for the group, and it's about talking about strategies to manage that anxiety about getting into a group.
So there's almost that kind of double impact where actually attendance at the group is useful in addressing the anxiety, as well as the other kind of principle intended.
Indeed,
right.
Yeah.
Okay, right, that's great. Next question. Do you use steps as a complete treatment? My understanding is that it's an adjunct to individual treatment, which means that we need capacity both to run the groups and also to see the patients individually thereafter, which can prove challenging.
Yes, so our service is contributing to the delivery of steps. So again, we work in this partnership model. So we look for that reinforcer. So those are those appointments that run alongside group attendance. It's our CMHT partners that are providing that part of the staffing resource, if you like, to offer that to participants. And also then beyond steps, what comes next? Our CMHT colleagues are likely to be keeping, those clients on their caseloads, etc. That's where we were keen to bring stairways on as an option, also to help with that longer term maintenance and giving people that longer period of time in contact with services.
Okay. How has the continuity, persistence of involvement of participants and also the outcomes for them compared between the previous face-to-face setup and the online delivery? Yeah,
we've not done that analysis as such, Gordon, because our service didn't deliver per se, you know, those face-to-face groups. So we don't have ready access to that data, but it is a piece of work that we would like to do to compare almost our, you know, engagement rates, any dropout rates, completion rates with those previous groups. So it is something that we have plans to do, but we haven't done that as yet.
Okay, that's great.
Claire, do you have any sense on that? Sorry, I know you were more involved in face-to-face groups than I was before the group service.
Just from our local team where I worked previously, but again, we would have to have more data from other community mental health teams. I think we'd have to ask for that in order to do a comparison study. Or
Okay. Are there any post steps like peer support groups where people have complete? I guess the stairway thing might link into that, but
yeah, very much so, and that's something that we are keen to think as we implement stairways. We're keen to think about that peer support, lived experience, facilitator element through that also. So that is something that we're in the process of exploring at the moment, and we're linking up. We want to have a conversation with, you know, through the BPD steering group in Glasgow about how we access that lived experience resource that they have access to. But participants create informal networks. I think that's what we've very much found. People join WhatsApp groups and they, you know, they post steps will have their own networks that they've developed.
Yeah. Right. Thanks very much. That was a really good presentation and really useful answers. And I think we've covered a lot of the ones that are there. There's maybe another 2 or 3 questions that we've not had time to get to just now, but as per the other thing, we'll nab you after the webinar and get some more info.
Thank you.
Thanks very much to you both. Okay, so I think we're almost sticking to time, I think, just now, but I'm going to hand over to Kirsty Ann McEwen, who's going to talk about a mentalisation based treatment.
Thank you very much. I've really enjoyed. Can everyone hear me okay? I've really enjoyed the speakers so far, so thank you very much. Really quite interesting. But thank you very much. My name is Kirsty Ann McEwen. I am an adult psychotherapist, mentalisation based supervisor and nurse therapist, and I work within NHS Grampian within our specialised psychotherapy service, and I've worked here for the last 12 years. And today I want to briefly talk to you about mentalisation based treatment and the treatment that we offer here in Aberdeen. Okay, could I have the next slide, please? I suppose, first of all, I wanted to speak to you about the psychotherapy service. I suppose just I've put a wee map here of Scotland and just kind of looking at our kind of geographical catchment area. So covering Grampian, you know, we're kind of a wide area, and we've got quite a lot of rural settings that we cover as well. And many of our service users have to travel quite far to kind of see us, which has at times has been really helpful and at times has been quite difficult. We also have referrals that we take also from Orkney and Shetland as well, so you can imagine that can be quite difficult accessing psychotherapy. So I think since COVID, we have actually been able to use the online system really quite well, really quite effectively, and that's actually helped with that kind of geographical difficulty that we cover. So we accept referrals from a wide range of secondary care services, so adult mental health, eating disorder services, substance misuse, older adult, liaison. So there's a few. So we do accept referrals from a wide range as well. And as well as MBT, our groups, we also have evening psychoanalytic groups that are run within the department, and we also have individual psychodynamic psychotherapy that we offer. And these services are for a wide range of mental health conditions, you know, including personality difficulties. And everybody that is working within our department has got a mentalisation based training or is working towards becoming a practitioner, as well as other psychotherapy trainings. Next slide, please. So I think just before I wanted to talk to you about our programme, I just wanted to have a think about what this term mentalising is. You know, what, you know, and why do we need it? Why is there a therapy that's been developed to kind of improve mentalising capacity? And mentalising is a process. It's probably an automatic process that we all do most of the time. You know, I'm doing it just now, hopefully talking to you. You know, it's when it's feeling, well, I am doing it, but I'm aware of, you know, feeling anxious, aware of my feelings, aware of how I might be coming across. I'm aware, you know, that I might be trying to mentalize, I might be trying to kind of emotionally regulate as I'm trying to speak to you all. It is something we have to stop and pause and think about and become aware of at times, but it is something that we will do regularly with others. And we learn to mentalize, you know, when we're younger, in relationships, within our kind of our whatever unit that we're brought up in, and traumatic experiences and how they're understood can have an impact on how we then develop our mentalizing capacity. So to be able to mentalize, we must kind of be able to see ourselves from the inside, what's going on for us, and looking at others from the outside as well, being able to kind of also think about what is going on relationally between us and another individual. So it's a form of imaginative mental activity about others and ourselves, what you imagine might be going on for the other person. And it's about being able to kind of manage those misunderstandings that we all have, and perceiving and interpreting human behaviour in terms of the intentional mental state. So our desires, our needs, our feelings, our beliefs, our goals, our reasons. And it's a relational concept essential for developing self-awareness and our sense of identity. And, you know, it allows us to self-regulate. And it provides us self-direction and can be vital for meaningful and sustained relationships. And if it's difficult, if we struggle to mentalize, it becomes difficult to self-regulate. We might jump to assumptions, we might make concrete statements, and it can cause some major difficulties in our relationships. The concept of mentalizing theory, it was kind of first thought about over 30 years ago at the Anna Freud Centre, and it was Peter Fonagy who then went on with Anthony Bateman to develop this treatment, which was originally for people with AUPD, and it's since then developed. It's now available for people with antisocial personality difficulties, eating disorders, and various other adaptations as well. And the aim of mentalisation treatment is to strengthen someone's capacity to understand their own mental state in attachment contexts, in order to address difficulties with affect regulation, impulse regulation, and interpersonal functioning. And, you know, the treatment that was originally developed and still is developed, and I know that it's running within, you know, other services within Scotland, is, you know, the form of 18 months treatment with individual sessions alongside as well. And that treatment was something that we did attempt to we successfully replicate probably about 10 years ago, but unfortunately we found within our service it wasn't sustainable in terms of the staffing levels, and we at that point had a therapeutic community which was kind of naturally coming to an end, and we had to look at our service and redevelop it and think about what we could be offering. And then this is when we had a look to kind of keep some of the principles of the therapeutic community and offer a day programme, which is called our Hub Day programme. Next slide, please. So in terms of this is our Hub Day programme, which has developed over time as well. Actually, it's actually changed within the time that I've worked here, because we used to offer it for a full day. Unfortunately, COVID actually has changed some of the ways we've had to run the service, but we're hopefully slowly getting back to that service that we were able to offer before. So in terms of in terms of what it looks like in terms of a treatment journey, so as I mentioned, we receive referrals from secondary care. And at that point, a psychotherapy assessment is done within the department, and a formulation is looked at. And in terms of that formulation, that can take up to kind of 2 to 4 sessions to decide whether mentalisation is something that, you know, is thought to be the best kind of treatment that might be offered at this point in time. And we spend time thinking about attachment relationships, thinking about that relational passport, about what might impact them getting to the group. And I was thinking about that question in the chat before about the anxieties that might be about coming into a group, what that might look like, how we're going to get you there, what's going to get in the way, what kind of difficulties do you get into with people, other people? Is that going to be a difficulty that might occur in the group? So we spend a lot of time on that formulation and thinking about those things with the individual. And after that is done, there's a meeting with the therapist, and there's also a meeting with the group as well, just to kind of have an experience of coming around the department, looking at things, looking at where they might be, what room they might be in, and also things like where do you get tea and coffee, where are the toilets and things like that. So it's trying to provide that kind of secure base. You know, people who are coming for MBT treatment are often in a place of that emotional dysregulation and mistrust. And the MBT therapists try to offer an environment that we can actually think about those things. I think we also had to think about that when we were doing MBT online, about things that have already been, I think, discussed with some of the STEPS colleagues, in terms of where are you going to be? Are you going to be safe? How is it going to be online? And things like that. We've had to really think about that with people as well. So the programme looks like this. So it's 24 weeks at the moment, and it's 2 groups in a day. So the first group is psychoeducation, MBTI basically. And what we look at there is mentalising, attachment theory, neurobiology, and things, and emotions, to name a few of the things that we do there. And that's very much kind of helping people just to kind of get to grips with what mentalising is, how it impacts them, and it's also giving people an opportunity to start speaking in the group as well. And we do that for 12 weeks, and there's always the morning group is always basically kind of some kind of education. So it's either psychoeducation, or we move on to MBT skills, which is where we might look at more kind of exercise-based activities. So it might be looking at kind of how we might manage our boundaries, looking at some kind of role plays that we might do, practicing the mentalising stance, being curious with one another, and we might use that then. But we also have a social break where everyone can kind of meet together, have coffee, which we really missed when we were working online together. And then we have our second group, which is in the afternoon group, which is our mentalising group, which is basically an environment, it's our training environment for kind of increasing mentalising with self, others, and relationships. So that might be where we might prioritise what might be discussed today. Something may have come up from the morning group, somebody may have been in crisis, somebody may have had a difficulty. We might need to prioritise that as what we might be discussing today. I'm trying to mentalise, trying to understand, or we might have other things that have come up that last week I was feeling like this, and I want to kind of continue thinking about that. So we will use that group to kind of, that's really where the whole day is therapy, but that is purely a therapy group. And the whole point with mentalising, you know, the therapist, you know, we're in that group to try and monitor levels of mentalise, try and kind of work out where we might need to intervene, try and help regulate some emotions. And the goal is, you know, is to stimulate just enough emotional responsiveness to explore new perspectives and find meaning, but not so much that mentalising collapses, that people are feeling completely overwhelmed and they can't tolerate to be in the room. So we're really quite sensitive to that, really trying to work on that with our service users. Next slide, please. So in terms of the outcomes, as I'm not sure if I've mentioned this already, but in NHS Grampian, we are actually the only MBT group only service in Scotland that I'm aware of. And I think there's another MBT group only service in the Netherlands as well. And we do, there is the individual part beforehand. There's the group, and we will be in contact with people if need be in between sessions. That doesn't often happen. Actually, people manage quite well. And then there is after the end of the programme, there is a 6 to 8 week review appointment where actually sometimes we offer further treatment. That might be a further mentalisation based group that we have in the department, or it might be that they might go on to individual therapy or one of our analytic groups as well. So some research was also done on this group only programme, and the outcomes were a significant decrease in global severity of interpersonal sensitivities, depression, paranoid ideation, phobic anxiety, and psychoticism. And there was a drop in interpersonal difficulties, and increase in work role satisfaction as well. And we continue to collect data in the form of SCL90s. We've just introduced the BPD, the 32 questions, and we continually collect data throughout the programme as well. And in terms of feedback from the group, if you can post the next slide, please. Just aware of time. So these were from some of the research that we've done. These were the emerging themes that came through from the group. So the feeling of not being alone, not being able to stop and think, improving and getting worse at the same time, which it would be something that I have experienced running over at least 30 groups, that there's a roller coaster of emotions, that some weeks people are feeling good, some people are feeling bad, and it kind of goes up and down throughout the treatment programme. And one of the things that we think about is finding it difficult not to put others before yourself as well. That's a theme that comes up, and that's something that the therapists work very hard to think about why that might be, that they can't take the time. Why do you believe that you're not as important as everybody else as well? And really try to be quite sensitive towards that as well. Next slide, please. In terms of the MBT adaptations, we have continually had to adapt our programme, and we did so during COVID, where we did meet online. We were all very quick to get back face to face. We had the luxury of actually having the space where we could do that as soon as we were able to, and we piloted going back face to face after COVID, which has worked quite well. And the staff, in terms of, are continually going on continued professional development. And we also take a lot of feedback from our service users about what needs to be kind of changed each hub day that we run. We ask for that feedback. And I also wanted to mention as well that we also have an MBT SMS group. My colleagues have been running that for the last nine years, and it's a 24-week programme as well. It's not the 2 sessions that the hub day runs, it's a 1-day session, and that has been successful as well. And my colleagues in eating disorders have also piloted an MBT eating disorder group there as well. And I'll just end finally, just last slide, just wanted to mention in terms of the training and links to other services, we run a 2-day MBT skills for mental health practitioners as well, which is well attended. And in terms of MBT supervision, we also offer that within the adult mental health services, substance misuse, eating disorders, and also into CAMS as well. And we also have, we're part of the MBT Scotland as well, which we recently ran MBT basic training and MBT practitioner. And I'm very aware of time, so I'm going to be quiet and pass you on to the next speaker. Apologies for going over.
It's okay. You had only a couple of minutes over, Kirsty Ann. Thanks very much for that. Delighted to introduce Tim Sporrell, who's now going to speak to us about dialectical behavioural therapy.
Yep. Good afternoon, everybody. Thanks for the opportunity to speak to you this afternoon about DBT and the borders. I'm aware there'll probably be quite a knowledge and experience of DBT in our meeting already, and I'm aiming to just give you a brief introduction and flavour of DBT in this presentation, and to talk more about the borders context. So next slide, please. So here's just a summary of what I'm hoping to talk about in this presentation, to give you a brief explanation, a bit about what to expect from DBT treatment, a bit about the evidence base, what we're doing in the borders, and a bit about evaluation, and with some resources which will be available in the pack at the end. Next slide, please. Okay, so the first thing to say about DBT is it was developed by Marshall Linehan in the 1980s. It has many similarities to cognitive behaviour therapy, with its focus on the relationship between thoughts, emotions and behaviour. There's an emphasis on dialectics, which I'll say a bit more about in a moment. And what's interesting is that Marshall Linehan was originally working with people that presented in A&E who were having thoughts about wanting to end their life. And she's more focused on how to help this group of people. But over time, it's evolved into a treatment that has an evidence base for people that have a diagnosis of borderline personality disorder. And the goal in DBT is to help an individual to create a life that's worth living. Okay, so next slide, please. So some of the key things to think about within dialectics is this idea, in a way, dialectics is about perspective taking. And we might start with a way of seeing something, and that might be what we call a thesis. There might be opposite ways of thinking about that position, that's the antithesis. And what we're working towards is developing a synthesis. And one way of trying to think about this is to sort of think about us looking at this cup together. So with this cup, I might be saying that I can see a cup that has different shadings on it. And perhaps from your perspective, you might be saying, yes, I can see that too, but I can also see a handle coming out towards me. And I might be saying, well, I can't see a handle. And we might get into a sort of debate about that. And so, but what we might want to try to do is, by working together, develop a synthesis, which might be sort of turning the cup around so that we can see the cup in a different perspective. And this might create a new starting point for us to have sort of further consideration. I might be saying, well, I like this cup because my son made it, and you might be having other opinions about it. And so we're sort of consistently sort of thinking about our experience and our interpretations of the world around us and of ourselves too. So this idea about sort of having opposing ways of seeing things is what dialectics is about, and thinking about how we sort of create a synthesis. And one of the primary dialectics that we're thinking about in DBT is this idea about acceptance and change, two things that seem almost opposite to each other, but we're trying to use those ideas both at the same time. So just to borrow some words from Marshall Linehan, acceptance is about a willingness to find the inherent wisdom and goodness of the current moment, entering into the experience without judgment, blame, or manipulation. And alternatively, and we're often doing that through some of the skills that we learn about in DBT, but we're also looking at skills that may help us to change situations about our life, about our experience. And we're using DBT skills to help us to lead to changes in our behaviour ultimately. So the idea about dialectics also includes some other themes that I'm hoping to just give you a flavour of here. So there's this idea about connectedness, which is one way of thinking about connectedness is the idea that although we're sitting in different rooms at the moment, our feet are connected to the ground, to buildings and the ground, and the buildings are connected to the land, and the land connects us in some ways. So even though we're apart, we're also connected in some ways. And we're also in relationship with each other. So I'm talking to you all at the moment. That's leading to feelings in me. I can feel quite nervous, wondering how this is going. And it might be leading to effects in you too, as you're listening to me speaking. And so in this way, we are all we're being shaped by each other's experience and the way that we're interacting with each other. So we're always in relationship with ourselves and in our surroundings too. And because of this constant evolving nature of our experience, we say that change is the only thing that is constant about our experience. And following on from the theme I was mentioning earlier, there's always more than one way to see a situation. It may not be apparently obvious to us at first, but it's nevertheless possible. And we're often trying to find a synthesis in apparently opposite situations. One way of thinking about this might be, for example, it can be a sunny day and it can also rain. Okay, and next slide, please. So I'm going to move on to talk about some of the components about being in DBT. One of the key components is attending a skills course. Skills courses happen once a week. It's often for a couple of hours, it certainly is in our service. It includes homework, and it's kind of a bit like a classroom type environment, really, sort of being there to learn about new skills. And the skills in DBT again sort of tend to form on this sort of dialectic that we're looking at between acceptance and change. And so on the acceptance side of skills, there are skills in mindfulness, thinking about acceptance, awareness and attention, and thinking about how we manage our emotions when we're acutely overwhelmed or in distress. So that's one side of our skills work, but the other side involves kind of change focus, thinking about our emotion regulation, how we understand our emotions, how we might sort of check the facts about situations and problem solve. And interpersonal effectiveness, we learn about thinking about the goal, the relationship and self-respect factors in our interpersonal interactions, and how we can develop skills to improve the quality of our interpersonal relationships. Okay, so next slide, please. So alongside attending a skills course, there's also an individual therapy component to DBT. And some of the features about being in therapy include completing a weekly diary card, where you'll be looking at recording and rating your emotions if you felt overwhelmed by emotions, and also any unhelpful or self-destructive behaviours that you might be engaging in over the course of a week. And then the goal is then to look at these, what's happened over the week with your therapist. And one of the key ways that we look at what's happened is using a technique called chain analysis. And in chain analysis, we're thinking about what might have made you vulnerable to a problematic event occurring, and then thinking through in sequence what were the thoughts, emotions and behaviours that occurred during that event. That might have included some unhelpful ways of coping with what happened. And so by doing a chain analysis, we can then begin to think about what solutions we might be able to bring to bear to the situation. And this is where our DBT skills can come in, helping us to learn alternative ways of coping and managing our own behaviour. So some of the other features about having DBT are the option to have phone consultation with a therapist, and phone consultation tends to be quite a brief phone call that's available to sort of check in and get support with using skills, because translating skills from a session to your everyday life can be challenging. And so having some extra phone support to do that can be very useful. And then one final thing to say about therapy is that for therapists, there's a weekly team consultation meeting, which helps us as therapists to think about our own practice, develop our skills, and yes, generally be able to support one another in the work that we're doing. So if we move on to the next slide, please. So this is the brief bit about the evidence base for DBT. There's a number of randomized control trials that support the effectiveness of DBT. And it says there's standard DBT, which includes both attending a skills course and having one-to-one treatment at the same time. And there's also an emerging evidence base for having a standalone skills course as a treatment. And so there's a reference at the end of this presentation that sort of gives you more information about those randomized control trials and where to look for them. Okay, so next slide, please. So I'm going to move on to say a bit about the context in the borders. So in the borders, we're a rural population of about 115,000. We don't have specialist services in the borders, so our DBT team sits within 3 community mental health teams that cover our region. We currently have 6 members in our team, although unfortunately 2 members are going to be leaving shortly, one on maternity leave and one is leaving the service. But each team member offers approximately 2 to 3 sessions a week of their time devoted to their DBT work. In the borders, we have 2 levels of intervention, which we call skills and program. So program is where a person would receive one-to-one therapy alongside attending a skills course, and skills is where you'd be attending a standalone skills course. And we currently have 3 staff who are able to deliver the individual component of DBT. There's a psychiatrist, a CPN, and myself. And so this is one of the limiting factors about what we can offer in the borders at the moment, in that we can only offer treatment to 3 people on our programme at any one time, because we only have the capacity to offer approximately sort of 1 session of therapy time for each of those practitioners. One final thing to say is that we receive external supervision from a very qualified and experienced DBT practitioner who's in Wales, and one of the advantages of the new technology we have available is that we're able to get support from far and wide in terms of supporting our programs in the borders. Okay, I guess one final thing to say is that on this slide is that because it's a limited resource, we have to think carefully about how we use that resource, and we're often going by the severity. We're often limiting our program option to people that have the most severe problems, who, for example, might be frequently presenting at A&E, who might be engaging in significant self-destructive behaviours. But we have another range of options available to which I'll go on to talk about a bit more in a moment. Okay, so next slide, please. So I've mentioned some of the challenges about having a limited staff team available. We need to maintain a good working relationship with our CMHT team managers to release some time particularly for our CPN to support the programme. So we're very grateful to our team managers for supporting us in that way. It can be challenging delivering treatment to a rural population. We've made good use of technology to help support us with that. But some of our other challenges include around data collection. Given that we're not meeting people in person for a large proportion of the time now, getting data back from people can be challenging. We're trying to use Microsoft Forms to help collect that data, but that's a work in progress. We haven't sort of cracked that one fully yet. And also other challenges are about trying to get data that can help support the development of the service. For example, it would be lovely to try and get data on pre and post attending therapy and how that might affect attendance at A&E or inpatient admissions, for example. But at the moment, we don't have computer systems that can support us with that kind of data collection. Okay, so next slide, please. Some of our strengths, I would say, are the way that we've been able to use the technology to support the treatment options. I think particularly developing standalone skills as an option is something we've done in the past year, and we're currently revising that. We've done our first run of offering that, and the standalone skills, it took us approximately 1 year to deliver 1 cycle of the DBT skills course. And what we're thinking that we're going to do is, because of our staffing limitations coming up, we're going to probably offer a shorter, perhaps a 20-week programme for our standalone skills option in the future. And another thing to say is that DBT fits within a range of psychological treatment options, from lower intensity options, which include things like Survive and Thrive courses. There's one-to-one therapy with a psychologist, and DBT programme is our highest intensity intervention. I'm aware of the time, so I'll just go on to the next slide, please. I recognise that we need to work on our data collection in the borders, but some of the audit work we've done over the years has sort of collected comments from participants in our programs, and there's some comments there on the slide there. So next slide, please. So here are just some resources and reference, which I hope that you may find useful when thinking about this, thinking about DBT in the future. So if we move on to the next slide, please. So just in summary, what I've hoped to do this presentation is to give you a brief explanation about DBT, what to expect from treatment. We've spoken about evidence base and the borders context, a bit about evaluation and some resources. And thank you very much for your time.
Thanks, Tim. Thanks very much. So Tim's not going to be able to stay with us for any questions, but if you put any questions in the chat box, we'll forward them on to Tim, and they'll be included in the next stage of the question and answers that roll out. So without any further ado, I'm going to hand you over to Kirsty Gillings, who's going to speak about schema therapy. Thanks.
Thank you very much, Gordon. Good afternoon, everyone. My name is Dr. Kirsty Gillings. I'm a consultant clinical psychologist working in the psychology department in NHS Fife. And I'm here to talk to you about our schema therapy treatment offer. Next slide, please. So I'm briefly going to cover today what schema therapy is for those of you on the call who might not be aware, and the evidence based on how effective that it is, and thinking about how we might be able to use schema therapy in NHS settings, providing the programme we've developed here in Fife as one possible example. And I'll also talk briefly at the end about how we have made our treatment as effective as I think we can make it, thinking about the governance that of structures we've put in place in Fife for schema therapy. Next slide, please. So I wanted to start first with a brief recognition that I know not everyone on the call today will be comfortable with the term personality disorder, that people may fundamentally disagree with that term or find it stigmatizing or shaming. And there may be other terms that people prefer, such as complex emotional needs or developmental trauma disorder or complex PTSD. And I want to be clear in my use of this term today, and that's largely dictated by the fact that schema therapy, along with most of the treatment approaches that we've been talking about today, have been developed and tested in research that's steeped in the diagnostic system that the term was created by. So in using the term personality disorder today, I want to be clear that that's a pragmatic decision that will allow for a shorthand description necessary in a very brief presentation. Gordon, can I have the next slide, please? Having shared that thought, I'm now going to give a very brief overview of schema therapy for those of you who may not be aware. So broadly, it's an integrative therapy which draws on a range of theoretical approaches and uses both cognitive, behavioural and experiential techniques to help people to change problematic life patterns. At the simplest level, schema therapy believes that for human beings to lead happy and fulfilling, contented lives, we need to have most of our emotional needs met most of the time. Emotional needs are universal and include among them the need to feel cared for, to feel safe, to feel connected to others, to be able to express our feelings, and to have a sense of competence and autonomy. Schema therapy argues that when these basic needs are not met well enough in childhood, human beings develop patterns of relating to themselves and others and the world that help us to survive at a time when we are largely powerless, but also and have little influence over what happens to us. And these patterns are known in schema therapy as schemas. So these patterns involve a number of ways of strategies for protecting ourselves, for example, through avoidance of relationships or numbing out emotional pain, or by adopting the views of others as our own, for example, becoming very self-critical or self-punitive. Now, these patterns work well for us as children when survival in an adverse or traumatic environment is our main goal. But they also get stuck and persist into adulthood when they're less useful to us and we have more agency over our lives. So, for example, it's healthy for a child who's being mistreated to view others with suspicion and to avoid them. But an adult who continues with this pattern is likely to feel depressed, lonely, or empty, and will not have healthy and sustaining connected relationships. When schemas are activated in the present, in the here and now, they're experienced on a moment-by-moment basis as what can be thought of as modes or parts of the self. So modes are literally the different sides that we all have. They're universal. So for example, if I told you that I had seen somebody in their raging bull mode, you would probably have a good idea that what I meant was that I had experienced that person in the moment as being extremely angry. We all have parts of ourselves. The self isn't a unitary concept. And in schema therapy, we focus on the parts of ourselves that take over and dominate our experience and cause us to act in ways which can cause us further distress or lead us into these patterns where, we're not leading fulfilled and happy lives. Schema therapy aims to break these patterns in adulthood using basically 3 types of strategies. So those that work on healing the emotional pain caused by past experiences, and there's a strong focus in schema therapy on working with the past, not just working with the present. In helping us to differentiate between then and now, so what's been triggered in the what wound from the past has been triggered in the present, and how is that affecting my experience in the here and now, and also crucially to change the way we respond to our schemas and modes such that we can get more of our emotional needs met in the present. Schema therapy can be delivered either individually or in groups, and has also been trialled in a combination of individual and group therapy. Can I have the next slide, please? So how effective is schema therapy? I'm going to summarise this just briefly today, and I will point interested listeners to the papers displayed here and the many others that are available. If we think as a whole, though, schema therapy has broadly been shown to be effective, both in alleviating psychological distress, reducing risky and self-harming behaviours, and in promoting recovery from personality disorder. And by this, I mean that there is a loss of diagnosis after treatment. Positive outcomes have been demonstrated in borderline or emotionally unstable personality disorder, avoidant personality disorder, and most recently, violent behaviour underpinned by narcissistic and antisocial traits. Efficacy has been shown both in individual and group modalities, and both a combination of individual and group. Schema therapy has also been shown to be cost effective, and that cost effectiveness has been demonstrated in a number of different ways, specifically in relation to health service utilisation, occupational performance, and quality of life. And finally, there have been a series of studies attached to many of the randomised controlled trials which have examined patient and therapist experience of schema therapy, which in the main has been largely positive. So both patients and therapists alike value the unique therapy relationship that's provided in schema therapy, which is known as limited reparenting, the specific techniques of schema therapy, and the clear theoretical model and problem conceptualization, which is especially appreciated by therapists. Dropout rates from schema therapy treatments are generally low. Can I have the next slide, please? Most of the efficacy trials, though, both individual and group, have been conducted in relatively long treatment protocols, lasting at least a minimum length of 1 year, some up to 4 years, for example, in the Bernstein forensic trial. And so we're talking in the main of upwards of 50 sessions of treatment, and sometimes considerably longer. In the last decade, though, there has been an increasing interest in developing briefer and testing briefer protocols, especially in group formats. And the reason for this is that it's hypothesized that some of the curative factors associated just with being in a group that we heard Alison speak about earlier can catalyze and accelerate the therapeutic effects of some of the schema therapy techniques. So these protocols, and there are several of them, are typically 20 to 30 sessions in length, with minimal additional input in terms of individual sessions or out of session contact. So they're designed to be delivered within routine clinical settings as standalone treatments. So these protocols have the potential to provide a feasible model of delivering schema therapy in public sector settings particularly, and also for maximising access to schema therapy. The majority of research trials to date on these protocols suggest that they can bring about positive change in psychological distress and personality disorder symptoms, although people with the severest difficulties are likely to need longer programs or other treatments before this one. And so it's to our local context here in Fife that I'd now like to turn. So we were in the process of developing an implementation program for brief group schema therapy when the COVID-19 pandemic hit. And whilst this was a setback in many respects, it provided us with the opportunity to trial an entirely online group offer. So ensuring some continuity of service that we could implement the model with some adaptations and have the benefits that digital technologies can afford us. In addition to that, the mixed urban and rural landscape of Fife also lends itself to digitally delivered therapies, and I know many other places in Scotland will identify with that too, because people can access treatment in their home without the additional commitment of travelling to a venue that may be quite far away from them. Our treatment protocol is 18 treatment sessions followed by 2 follow-up group sessions and runs weekly over a 6-month period. The group's attended by 10 members and 2 facilitators. And our protocol, unlike some of the others, is largely experiential in nature. Our cognitive and behavioural elements tend to be provided through homework tasks. Sessions are 90 minutes, with the first part of the session, the first 30 minutes, is dedicated to the here and now of being in a group and the interactions that arise between group members. We then generally have 45 minutes dedicated to the group's work task for the day, which encompasses across the programme all of the experiential techniques of schema therapy. For those of you who are familiar and for those of you who are not, that includes imagery rescripting, historical role play, chair work and mode dialoguing. The programme also includes an experiential psychoeducation component. There's a strong focus on processing the childhood origins of schemas and some of the experiences that have underpinned them, and a here and now phase towards the end, which includes a focus on the group ending. Can I have the next slide, please? So we began our first group cohort in April of 2020, and to date we have completed 5 groups. Our 6th is currently running. I've come from it this morning, and we have a 7th recruited to start in January. About 50% of the people who come to our programme have a formally diagnosed personality disorder, but many more clearly meet diagnostic criteria but do not have a formal diagnosis. All of the patients in our programme have complex and chronic interpersonal problems. Most have had a substantial history of formal psychological treatments, which they've either had limited benefit from or there has been a propensity to relapse in the presenting problem. Due to the experiential focus of this group protocol, those who have sustained or substantial risk behaviour are directed first towards stabilisation treatments within our complex PTSD and personality disorder pathway. Equally, we have found that those who have PTSD as a primary presenting problem, we direct those to reprocessing treatments first. We learnt early in the delivery of this programme that whilst those with a primary PTSD diagnosis can work effectively on their interpersonal issues in group, the brief nature of the protocol that we use means that there isn't enough reprocessing through imagery rescripting to affect change in re-experiencing symptoms. So we generally recommend that people will go and do re-experiencing, and then if they need to, still come back to work on their interpersonal issues in group. So we've just completed our initial outcome and analysis, which I wanted to show here, and this is a quick and dirty analysis, so I will answer what questions I can on it. So we have had a very, very low dropout rate. Overall, that has been 20%, but this data is actually skewed by one group where our dropout was 50%. Typically in a cohort of 10, we will lose one person during that process. And we've had one group that started that everybody completed. As you'll see from our attendance figures, our groups are extremely well attended. People don't tend to miss our sessions, and when they do so, they tend to do so with advance warning to us and the group. I think that this is largely down to the commitment that people make to themselves, but also to the others to be present and to work with each other during the group. To date, and I'm touching wood here, we've had no adverse events during the programme, despite some of the quite complex work that we undertake during it, and despite the severity of the symptomatology at baseline. We do have quite a severe group who have taken up our offer for this treatment. In terms of outcomes, our initial analysis has suggested that we are seeing significant change in global distress, lower levels of distress, and also we think due to the focus on group process, changes also positively in interpersonal sensitivity. We didn't see changes though, we predicted we might see changes in levels of hostility, but that hasn't been the case. Despite the briefity of the programme, we've also found significant change in personality variables. So again, in the right direction for 14 of 18 schemas on the YSQ. And we've found significant changes in all modes, specifically targeted in the programme and in the predicted direction of change. So vulnerable child, angry child, inner critic and detached coping modes have decreased, and healthy child and happy child and healthy adult modes have increased in our initial analysis. Our clinical effectiveness data analysis is slightly lower than that of the published trials. And I expect this is partly due to the higher baseline severity of our group than those in the published trials. But equally, we have other hypotheses around why this might be the case. And those relate primarily to the therapist experience and also to therapist pairings that we're yet to examine through our analysis. Next slide, please. So I wanted just to take a moment to think about what has made this treatment effective, and I think more effective than most of us, including myself as a schema therapy, somebody passionate about it would have thought. But part of what I think has made this programme effective is the lengths that we have gone to maximise treatment fidelity in the time that we have available in the programme. So as far as has been practical in a routine clinical setting, we've instigated clinical trial style conditions as far as we can. So that's include manualising the programme. We specifically train clinicians in delivering this programme before they become group therapists. And we've also chosen therapist pairs carefully and matched them so that they will complement each other and also be able to contain and manage the very complex group dynamics and emotional states that can arise in these groups. We also have standardised procedures for assessment, interim and final evaluations, which are conducted individually. We've gone to some quite considerable lengths to ensure adherence to the protocol. Now, initially, this was through weekly expert supervision from someone in the Netherlands. Now we have weekly peer supervision that all group therapists attend, where we process what's happened in the group in the week, and we have expert consultation as needed. We also produce very detailed process notes, much as a psychoanalytic psychotherapy group might, so that we can spend some time thinking about and reflecting on what has happened in the group and the ways in which we as facilitators have also been responding in that environment. We found these levels of supervision and guidance essential in managing groups on a week-to-week basis, but also in containing therapists so that this feels manageable to deliver. And that process has allowed us first to pilot and then to refine and finally to embed the group programme, which is now an established part of our treatment offer. And finally, I would say this programme sits within the broader schema therapy governance structure in our department, which includes certification level training and supervision. We currently train 2 clinicians per year. Group supervision more widely, which includes skills practice. This is regularly attended by 12 to 15 clinicians who are practicing schema therapy. And the aim is to ensure that expertise is distributed widely at different levels of practice, rather than reliant on one or two individuals in our department. Thank you very much. That's me, Gordon. Thanks.
Thanks very much, Kirsty. We're running a wee bit over, so I'm going to move straight into the questions a bit just now. Just want to pick up on the point that's been made by Vic Nair around about the contentiousness of the diagnosis, the use of language, and talks about ignoring the contextual factors, and the mentions that, you know, moving away from the focus of the diagnosis leads us to treat the problems as if they reside within the individuals. That's not at all how I think this programme has approached the nature of personality disorder. We've spoke from the very beginning about the contentious nature of it, about the various kind of challenges, and a number of the previous webinar events that we've held have addressed those points very specifically. We're also working very closely with our colleagues in Scottish Recovery Network and Vox roundabout, engaging with people with lived experience. It was great, Kirsty, that you acknowledged that point, but it's not an alien point to this programme at all. Right, so I'm going to go straight into the questions. So unfortunately, as I'd mentioned earlier on, Tim's not going to be with us for this section, but we'll forward them to him. So the first question around about MBT is, do you think the basic awareness or introductory skills for clinicians who would not be involved in delivering MBT, but maybe working with patients who are receiving it, would be of benefit to deliver other interventions in an MBT informed way?
I think at the end of that, I spoke about the MBT 2-day skills training that we run. And I think that's MBT Scotland wide. I think most of the MBT teams, they have a 2-day skills training that's offered for all kind of mental health professionals, and we have had other professionals working on that as well. And I think they have found it quite effective coming along and learning about what MBT is, how they might use some of the interventions, how they might use that with people they're working with. I know that I have done lots of different skills trainings, actually working with health visitors in the past, as well, just trying to kind of think about some of their patients that they're working with as well. So I think, yeah, the answer is yes. It would be good.
Okay, and regarding schema, with schema therapy, does the age of patients come into the scenario? Lots of my patients are over 65 years, where attachment, relationship, self and others regarding substance use have become a crutch. So I think the question is basically, does the age of patients come into the scenario when working in schema therapy?
Not at all. So our groups, we aim to create a mini society, because that most closely reflects people's experience. So we have had people in their 70s in our groups, and actually groups work better the more diverse they are in our experience.
Thanks. So back to DBT, no, it's not the DBT, back to MBT. Are you aware of any other services that have adopted your hub day model?
No, I'm not. No.
Good answer, good short answer. That's what I like when we're at this stage of the proceedings. We're running really short of time. Back to schema. No, I think that is the question that we've got for schema. So back to MBT, we're bouncing a bit like a tennis match. Are there any specific difficulties in adapting and delivering the model online?
Very much just share a lot of what my colleagues have said today about the difficulties in terms of accessing space, access to technology. We had one person, I remember in the group, he couldn't hear us. It was really difficult. He was becoming quite frustrated. In terms of the adaptation of the model, MBT is quite active. We're quite active in the room. It became a bit more it had become more difficult to run it that way. However, it is manageable, because I know that I've got lots of colleagues who still are running MBT online, and it's really quite effective. I think that, you know, it depends. It's very much acknowledging those difficulties in the room, bringing them into the awareness, what we're going to do with that, thinking about what the group values as well, what they can actually do to try and manage some of these difficulties. And, you know, there's practical ways of managing it as well. So
we've got 5 minutes left in the meeting. So there's one final question, which is, in each MBT group, do all of the service users have a diagnosis of BPD?
When they've come through our psychotherapy service, most people do have a diagnosis of BPD, but they also have maybe ADHD, autism as well. There's also other traits as well. And actually, some of the time it's maybe not a full diagnosis of BPD. They have some traits. But I suppose the whole point of the group is that there's a difficulty in mentalising, and that's what they're wanting to work on. And that would be the focus of that group. We do have one session which is on personality disorder, and it addresses quite a lot of the things that you know has been discussed today around diagnosis, how helpful, unhelpful it is. You know, it's about your identity, who you are, and it addresses some of those aspects as well. And I could go on about it for a long time, but I know we're short of time.
Okay, so thanks very much to all of the speakers. All of the questions will be compiled. We'll have answers for them all, and we'll send them out to all the delegates. Thanks very much for everyone that's attended, and in particular, thanks very much to our speakers. So we've just got a bit of evaluation that we'll run just now. So if we can move the slides along onto that, please. So the polls will come up on the screen, but they'll also be there in the chat. So if people can please just take a couple of minutes to answer those, that would be fantastic. And while those are firing away, I'll do a trailer for our next event, which is going to be on January, let's say the 19th. It's going to be on January the 19th, where we're going to have a workshop delivered by our colleagues from CME round about reducing stigma, with a specific focus on people who may attract a diagnosis of personality disorder. I think that's all the polls completed. Next slide, please. There we go. The next event. And next slide, please. If anyone wants to get in contact with us at the programme to have, discuss any kind of aspects of the work that we're doing, please do. Details are there. And I think that's us. Thanks very much, everyone. See you later.